We are live.
Hi, good morning, everyone. Good evening and good afternoon, wherever you are in whichever country. This is live on the global platform. We are live in with more than almost 2 million subscribers, most of the countries. This is an international weekly meeting, COVID edition in association with SEMAO, 81st edition. This was started 81 sessions back. Generally a think tank, a roundtable for all the national medical associations. We are on Saturday, 23rd of October, 9:30 a.m. as an Indian Standard Time. It is always our endeavor to bring knowledge. Before we can start this session, I just want to talk about we have Perfect Health Mela, which was started by Dr. K.K. Agarwal, who was the past president of SIMAO. Uh, this is a 28th edition, and the purpose of Perfect Health Mela is to bring awareness. So I believe when Dr. Heidi joined, we had a Zumba session going on. And before that, we had a spiritual session. Before that, we have a health session and then the yoga session. We have children's school competitions, yoga, everything on this platform for the 4 days. And we have a viewership of almost a million people watching it. The concept of this is mass awareness. We bring a kind of a theory where we say you don't really rely on medicine, keep healthy, eat healthy. We also have a cooking stuff over here where people come and present. So this was Perfect Health Mela. This live on 20 to 24th, and we welcome you at a special edition today. Uh, we will bring up the update from the National Medical Associations. Meanwhile, we have a short presentation coming up. The topic of the presentation today is uh, okay. So the topic of the presentation is Transthyretin, cardiac amyloidosis, myth, challenges, and solution. And to present this topic, we have Dr. Saurabh Malhotra, MD, Director of Advanced Cardiac Imaging, Associate Professor of Medicine, Cook County Health and Rush Medical College, USA. Dr. Malhotra is also holds an academic rank of Associate Professor of Medicine at Rush Medical College. Dr. Malhotra is a multi-modality imaging cardiologist with a focus of effective application of imaging for promoting patient care while reducing the resource utilization. His clinical and research interest is in imaging. Uh, he established the direct of cardio amyloidosis program for Cook County Health. So I request Dr. Malhotra to share the slides. So over to you, Dr. Malhotra.
Thank you, Saurabh, for that kind introduction. I hope you all can hear me well. It's an honor to be in your midst today. I'm going to be talking about transthyretin cardiac amyloidosis, myths, challenges, and solutions. Now, I know this is a worldwide forum, and we're all dealing with a pandemic all over the world. Hopefully, you all are safe and healthy, and people are doing better in your respective countries. Um, there is, I want to highlight the fact that even though we are dealing with COVID and have been dealing with for the last couple of years, cardiovascular disease still leads in terms of mortality and morbidity, not only in the United States, but all over the world. And there is much more to medicine and taking care of our patients in addition to the challenges that we are facing with COVID. And I wanted to take this opportunity to highlight a topic that, a disease condition that we don't think about as much, but it's definitely increasing in incidence and prevalence, definitely here in the United States, and I believe there is a heightened awareness about this condition all over the world. So I'm just going to take a few minutes talking about some background about what cardiac amyloidosis is and what's its pathogenesis. We know that there are two major types of amyloidosis that we deal with in clinical practice. The AL or the light chain amyloidosis and the ATTR or the transthyretin amyloidosis. We're going to focus today on transthyretin amyloidosis. Transthyretin is a tetrameric protein. It looks like a four-leaf clover as shown here, which is normally produced by the liver and has a function of carrying vitamin A in the body. In certain conditions which lead to genetic mutations, from genetic mutations leads to dissociation of this tetramer into dimers, which are unstable, and these result in formation of these amyloid fibrils, which are insoluble, resistant to proteolysis, and then get deposited in the heart and actually in various systems of the body. So even though I'm a cardiologist, I'm talking about cardiac amyloidosis. I see amyloidosis as a systemic disease, similar to much like diabetes, which is actually also a systemic disorder. These are several different types of amyloidoses. Primary or AL amyloidosis results from light chain abnormalities in patients who have multiple myeloma. And then we have the TTR form of amyloidosis, which is of two types, the mutant variant or the hereditary transthyretin amyloidosis, or the senile systemic, which is now called as the wild type amyloidosis. Now, amyloidosis is a worldwide disease, and the prevalence of the senile systemic variant, also called as the wild type amyloidosis, has been reported to be about 25% in patients above, or people above the age of 85 years. Men are more often affected than women in this condition. However, the mutant variant amyloids are based on specific populations. So especially in the United States, we have a predominance of V142I or V122I mutation, whereas in Portugal, Sweden, and Japan, the predominant genotype worldwide actually is the V30M mutation. And in the Irish population, it is the T60A. Now, knowledge of these mutations is somewhat important because this is what results in the heterogeneity in this disease. If you have an early onset of disease and you have V30M mutation causing amyloid, you're likely to have more neurological symptoms. Whereas if you have a V142I genetic mutation and the disease onset is late, you're more likely to have cardiac manifestations. And there's several ways in which in which this disease can present, ranging from carpal tunnel syndrome in both hands, neuropathy, autonomic dysfunction, orthostatic hypotension, syncope, and in the end, cardiac manifestations and pump failure. Knowledge of the gene mutations has been shown to be important. This is a study from atherosclerosis risk in communities in the United States, showing that carriers of the V122I mutation or V142I mutation actually had a worse survival when it comes to heart failure than patients of the same racial background, but who are not carriers of this mutation. The type of mutation that the patients may have also decides the penetration of the disease, by which I mean is when does the disease show its ugly head. So if you have the leucine 111 methionine mutation, there is a very early onset of this disease, whereas if you have the wild type mutation, the disease onset is late. Our oldest patient that we diagnosed here was about 94 years old. The youngest is about 54, right there, who has a very rare serine 70 arginine mutation. Now, in terms of epidemiology, and we all are now talking a lot about epidemiology, especially when it comes to COVID. So I'm going to use that to talk a little bit about amyloid as well. Now, this is a graph that's taken from a paper that was talking about AL amyloid and it being a disease of the middle-aged population. In contrast, TTR amyloid is a disease of the aging population, and there's an increased prevalence in patients above 80 to 90 years of age. This is based on biopsy specimens showing 50% of patients above 90 years of age had some evidence of amyloid in their heart. This is a decade data in the United States showing that in 2012, the prevalence of amyloidosis was right at the threshold of what we would call a rare disease. So this is almost a decade old. So I'm suspecting that this is definitely much higher than what it was in 2012. And this was from a sample of patients who were admitted in the hospital. So it's very likely that this was an underestimate even at that time. And the disease prevalence is much higher than we actually suspect it to be. So autopsy studies have shown that among patients above 85 years of age, there's a 25% prevalence of cardiac amyloid deposits in the heart, 10% prevalence in those undergoing bilateral carpal tunnel release, and a substantial proportion of patients who have heart failure and those who are undergoing transcatheter aortic valve replacement. So is amyloidosis a rare disease? If you look at AL amyloid, at least in the US, only 2,500 cases annually, with only 50% of them having cardiac involvement, I would say it's a rare disease. With the hereditary form of amyloid, if you just talk about um, in the US itself, 4% of Black population in the US of the African Americans are actually carriers of the genetic mutation. So there's several thousand cases. And if you look at the wild type or the senile systemic mutation, there's at least 1 million patients who will have transthyretin amyloidosis. Now, the clinical challenges, and I know the theme today is myths, challenges, and solutions. I'm going to talk about myths and challenges in tandem and then go on to solutions that we have now. So this is a typical progression of amyloidosis in a patient. It starts typically with carpal tunnel syndrome or neuropathy several years to a decade before the diagnosis with cardiac manifestations. And we had a patient who we recently diagnosed. He was a 74-year-old male. He was admitted with atrial fibrillation and heart failure. He was a painter by occupation, had neuropathy and carpal tunnel syndrome, and those were all attributed to him being a painter, and the diagnosis of amyloidosis was not thought of in that patient. We all talk about heart failure therapies in patients who have low ejection fraction and heart failure and want to be aggressive in their medical management. But in patients who have cardiac amyloidosis, traditional heart failure therapy that's employed is actually counterproductive. These patients have restrictive cardiomyopathy. They have a fixed stroke volume, so they need their heart rate to maintain a cardiac output. And what we do in heart failure management is actually blunt that response. So patients actually feel badly when they are put on beta blockers and heart failure therapy, such as ACE inhibitors, which also potentiate autonomic dysfunction and cause orthostatic hypotension. Medications such as digoxin and calcium channel blockers bind to amyloid fibrils and actually increase toxicity. Now, traditional thinking was that if you have features of left ventricular hypertrophy and an obvious cause, such as hypertension, is if you have a patient who has hypertension or aortic valve stenosis, then don't think about amyloidosis in those patients. We know this is not true anymore. TTR amyloidosis is the disease of an aging population. They often have long-standing hypertension. Left ventricular hypertrophy is common, and aortic stenosis is common in these patients. So just because patients have hypertension and aortic valve stenosis doesn't mean that they cannot have amyloidosis concomitantly. And this is an example of one of the first patients that I diagnosed here, who was an 84-year-old white male, had severe symptomatic aortic stenosis, and you can see very tight calcific aortic valve here, severe left ventricular hypertrophy. He underwent transcatheter aortic valve replacement with improvement in his valve function, but did not result in any significant improvement in his symptoms. And a study has shown that a substantial proportion of patients who were diagnosed with cardiac amyloidosis actually carry a diagnosis of hypertension, coronary disease, and other comorbid conditions for a very, very long time. And we must acknowledge the presence of this condition with other comorbidities. This is an example of a patient who had triple vessel disease, who was referred to us for viability testing. And while we found that he did have myocardial viability on his cardiac MRI, we did find features suggestive of cardiac amyloidosis, and we did diagnose him with cardiac amyloidosis. The patient was unfortunately treated with typical heart failure therapy. Our doctors did not listen to us 5 years ago, and he did not do very well. He had multiple hospital admissions after being discharged following his bypass surgery, and The only after reduction in his heart failure regimen and discontinuation of antiarrhythmic agents did he actually significantly improve. So in medicine, we are all taught, and it's ingrained in our minds, to think about the Occam's razor, which is think of one diagnosis that can explain everything. But in patients who have amyloidosis and transthyretin amyloidosis, this really does not pan out. And we must think of Hickham's dictum, which implies that a person can have as many disease as that they desire, or there's no limitation to how many disease they may have. And amyloidosis is one such condition in which the patients can have several other medical problems that can mimic each other. The other myth in amyloidosis is that heart failure with preserved ejection fraction or normal ejection fraction is a classic phenotype. This is an example of a patient who has severely reduced ejection fraction. Actually, this gentleman was from South Korea. Again, he had significant multivessel disease. You can see how tight his right coronary artery is. And his MRI also showed amyloidosis, which was confirmed on a pyrophosphate scan that we're going to talk about. So we did a retrospective study at a small scale at our hospital, and we found actually almost 1/3 of our patients who had cardiac amyloidosis actually had low ejection fractions at the time of diagnosis. So just because a patient with heart failure has a low ejection fraction does not necessarily mean that they cannot have cardiac amyloidosis. So this figure shows the diagnostic challenges and the dogmatic teaching that we have had for this disease. Several of these patients don't present with heart failure. Heart blocks are only present in a minority of these patients. Low voltage EKG is thought to be a hallmark, but it's only seen in about 20%. And patients can have asymmetric left ventricular hypertrophy as well. So another challenge is a complicated diagnostic evaluation. As you can see here, mentioned in this figure, it's so complicated that even I can't keep it straight in my mind. And then tissue biopsy is considered the gold standard. Now, if you have patients who have history of fatigue, weakness, syncope, breathlessness, this paper would suggest that you should biopsy these patients to look for amyloid. And we really do not do this in clinical practice. So what are the solutions? So going forward, we're going to talk about solutions for cardiac amyloidosis. So we must identify certain red flags that seem to segregate more often in patients with cardiac amyloidosis. I like this paper because it says heart failure and does not subcategorize these patients whether they have a normal ejection fraction or a reduced ejection fraction. So if they have heart failure, if they have thick ventricles, and if you think that they may have cardiac amyloidosis based on several features, which are bilateral carpal tunnel, low voltage EKG, this cherry on top pattern on echo, and certain other advanced imaging tests such as cardiac MRI. So we have solutions for imaging cardiac amyloidosis, and there are several of these. We can image the hypertrophy, we can image the amyloid fibrils, we can image the extracellular volume in the heart. So the field is really expanded within the last few years. Echocardiography is often the first step. It's widely available. Almost anybody can get an echo. And these are typically what an echocardiogram would look like. You'll see severely thickened left ventricle. You'll see pericardial effusions. You'll see right ventricular hypertrophy. You'll see hypertrophy or thickness of the interatrial septum. And you'll have a restrictive physiology, which is a classic in patients with amyloid. Something that we rely on a lot is deformation imaging or strain echocardiography, and we see this typical cherry on top pattern. The cherry is in the middle here, looks like a bullseye, and this has been shown to be very sensitive for prediction of cardiac amyloid, though its accuracy has been shown to be reduced in patients who have chronic kidney disease. So it's a very sensitive test. Echo is a very sensitive test, very easily available, but it is not specific for amyloidosis as well, because these features can be seen in patients with hypertensive heart disease, chronic kidney disease, so on and so forth. Cardiac MRI, on that other hand, is very accurate for amyloidosis, very high specificity. You can see varied patterns of amyloidosis. This is diffuse subendocardial enhancement on late gadolinium enhanced MRI. Although it's very specific, it does not differentiate between the types of amyloid. So these are two different patients with very similar appearing cardiac MRIs, but patient on the left actually has transthyretin amyloidosis, whereas patient on the right has actually light chain amyloidosis. Now, MRI is very useful to follow treatment response, and this has been shown recently from a study from the United Kingdom by Mariana Fontana, showing that using targeted therapy for amyloid and applying MRI, they have been able to measure a reduction in the burden of amyloid fibrils in these patients. Now, we now rely heavily on bone scans, bone scintigraphy for cardiac amyloidosis. Now, some historical perspective on this. I was not even born when this test was being used to diagnose myocardial infarctions in the 1970s. But this was superseded by newer tracers that we all now use across the world for stress testing. Okay. Now, there were then reports of this isotope being taken up by the heart in patients who undergo bone scans. Who gets bone scans? Elderly male who have prostate cancers get bone scans. So it is not surprising that elderly men who have prostate cancer also tend to have, or are the same people who actually also suffer from wild type or the senile systemic amyloidosis. And probably that was the reason why soft tissue in these patients and the heart in these patients who were getting bone scans was actually lighting up with this isotope, which is actually a calcium phosphate binding tracer. So now, fast forward in 2021, we are now using this technique to diagnose patients with cardiac amyloidosis. We're not going to go in details of how this test is done, but it's widely available, at least in the United States, and I know several other countries as well. If you have a lab in your city or wherever you work that is able to do a technetium stress test, that lab has the capability of doing a pyrophosphate scan or a bone scan for cardiac amyloidosis. This test has a very high accuracy for specifically for transthyretin amyloidosis. And if you have ruled out AL amyloidosis by checking for monoclonal proteins, the specificity was reported to be almost 100%. So it's a very, very, very specific test. So what is the solution? So diagnostic evaluation was complicated. It is not complicated anymore. There's a paradigm shift in 2021, actually we're going to 2022 soon. So the focus is on imaging-based diagnosis of cardiac amyloidosis. When you suspect based on clinical features, you perform a bone scan. If the bone scan is positive, you're done. Patient has cardiac amyloidosis when the monoclonal proteins or AL amyloidosis has been ruled out, and only using biopsy and histological confirmation in patients who have intermediate tests, which is by far very few these days, at least in our clinical experience. So I'm going to keep going because I want to discuss some cases here. So we have excellent tests that we have, but again, we must not forget that we are all clinicians and physicians. We must rely on our clinical acumen in the end. This is an example of an 81-year-old lady who had heart failure, low voltage EKG, left ventricular hypertrophy, again, cherry on top pattern on echo. She had a diagnosis of TTR amyloidosis based on MRI and bone scans. However, she also had features which were suggestive of a plasma cell dyscrasia. She had elevated kappa lambda ratios in both serum and urine, and she had an IgA kappa expression on immunofixation electrophoresis. So our hematology colleagues thought that she has a myeloma. She had a bone marrow biopsy that showed 18% plasma cells. However, she did not tolerate chemotherapy very well, and patient was made palliative with discussions for hospice treatment here. Patient was seen in our clinic, and she actually was doing okay. We escalated her heart failure therapy, specifically with a specific focus on diuresis, diuretic regimen. She was started on targeted therapy for amyloidosis, had complete hematological stability, and actually clinically improved. And again, we're living in the COVID era. This patient of mine also survived COVID-19 infection last year and is still continuing to do well. So what this lady actually had was smoldering multiple myeloma. She did not have the typical crab features that we see in patients who have multiple myeloma. So because of her age, she had transthyretin amyloidosis, but elderly patients also have myeloma precursors such as MGUS, monoclonal gammopathy of unknown undetermined significance, and actually smoldering multiple myeloma. Another conundrum that we have in patients with amyloidosis is we think that amyloidosis is a diffuse disease. It should involve the heart completely when we see these patients. And this is an example in which there is diffuse involvement of amyloid in the heart on a PYP scan. This is what a negative scan would look like. But when we see this, there is a very faint uptake in the septum in this patient. So actually HAC has focal disease in very early amyloid. So we are now steadily going from diagnosing patients with frank heart failure having amyloid to actually now diagnosing them at a disease state where we actually have the capability of preventing the morbidity that can happen from this disease. So the solutions for therapy, if you go back over a decade, we would say we have no treatments available and these patients should only be subjected to supportive therapy. But now things have changed. There are targeted therapies that are available for transthyretin amyloidosis, and I'm going to share a few slides on the latest data on these treatments. A first class of drugs is called as TTR suppressors or silencers. The two types that are available now in the market, at least in the US. Inotersen, it cleaves the mRNA. Now, we all know about mRNA now because of the vaccines that have been developed for COVID. So these drugs actually slice or chop out the mRNA that makes this protein within the cells. Inotersen does this in the nucleus. Patisiran does this in the cytoplasm. So when that transthyretin mRNA is destroyed, no more protein is made, and thus you reduce the levels of transthyretin. And this was studied in two randomized trials, the NEURO-TTR and Apollo trial, that showed a significant reduction in this transthyretin protein, which is the pathologic protein causing amyloidosis, after administration of these medications. Now, in 2021, this is very exciting, and I think this is where the field is going to go in the future, is with in vivo gene editing for this disease. Using CRISPR-Cas9, 6 patients were tested with this type of gene editing, in vivo gene editing, by which I mean that this CRISPR-Cas9 was actually able to home in on the liver and destroy the abnormal gene within the liver that resulted in complete reduction, actually significant reduction in this abnormal protein production from the liver itself. So only 6 patients were studied, but I think more studies like this are going to come in the near future. Moving on to other classes of drugs, the TTR stabilizers. Tafamidis is the one that is approved in the US. Diflunicil is available for off-label use. Tafamidis has been shown to reduce heart failure or cardiac-related mortality in patients, but takes about 1.5 years for the events to be differ between patients who received the drug from those who received placebo. A combination of doxycycline and taurursodioxycholic acid, which is a bile acid binding agent, have been shown to disrupt amyloid fibrils in preclinical studies, but no clinical studies have shown their efficacy as of now. Now, in the future, several drugs are going to be coming out, hopefully over the next couple of years. This is a three-dimensional structure of the transthyretin protein. As I said, it has a 4-leaf clover structure. You have 4 monomers that join together to form the tetramer. There are these mutations that disrupt this tetramer, resulting in dissociation and destabilization. However, there is a benevolent mutation that is present in some patients, the T1119 M mutation, that causes stabilization of this protein. And then there is a medicine called acoramidis, or AG10, that behaves similar to this mutation, and which is now being studied in phase 3 clinical trials, and may be out next year or the year after. So there is a sprint in this marathon. We cannot wait for these drugs to come out, and we cannot wait for 1.5 years for our patients to feel better. Palliative and comfort care are options, but they're not the only options. Non-targeted symptom management is also very important and actually allows for patients to feel better on a short-term basis. Diuretic therapy using loop diuretics is the mainstay, and then cautious use of heart failure therapies, or traditional heart failure therapies, must be employed. Now, this is a real challenge and has been a challenge with my heart failure colleagues, to encourage them and to inform them that they must be less aggressive with heart failure treatment in these patients with amyloid, and that education is ongoing. These patients suffer from several other issues such as orthostatic hypotension, gastroparesis, and several arrhythmias such as atrial fibrillation, which are also very challenging to manage. And thus, management of amyloidosis, cardiac amyloidosis, not only revolves around targeted therapy towards the disease, but also non-targeted symptom management that improves the patient's symptoms on a short-term basis. So just to recapitulate now, what are the myths? Transthyretin amyloidosis is a rare disease. It's not, as I showed you. The disease prevalence, of course, will depend upon the population that you serve, the country that you live in, because that may decide the kind of genotype that may be prevalent in your population. Certainly in Chicago here, we have the V142I mutation. We suspect, and if you just did the numbers using a 4% prevalence of that mutation, that about 60,000 patients in Chicago are carriers of this mutation. If you are in Europe, you'll be struggling with the P60A in Ireland, or the V30M mutation in the UK, and actually also in Japan. So it's not a death sentence. Palliative and supportive care only is not the only option. We are now giving transcatheter valves and clips to our elderly patients, so why not treat them effectively for amyloid? HFpEF is not the classic phenotype. Several of these patients may actually have reduced ejection fraction, so one should not omit the thought of these patients having amyloid just because they have low EFs. And heart failure therapy that we use aggressively in our patients with heart failure actually can be detrimental in these patients. What are the challenges? Long delays in diagnosis. They're often overlapping clinical features. There's a lack of awareness about the prevalence, diagnosis, and treatment available. We have lots of tests that are available now, and a lot of studies are going on all over the world. I know in the United States, a lot of MRI studies are going on. I know in India, people are very interested in doing PYP scans in Delhi, in AIMS, and we must, however, recognize that this medical problem can coexist with other conditions. And just because somebody has hypertension, aortic stenosis, or coronary artery disease does not mean that they cannot have cardiac amyloidosis. So what are the solutions? We must understand better the disease prevalence and its distribution in the community. It is a disease of the masses without any barriers. Just like COVID, there are no barriers with this disease, especially when it comes to the wild type amyloid, because it can occur anywhere all over the world. Diagnosis is important not only for the patient, but also for the family members, especially if you have a mutant variant form of amyloid, because this can run in families and then thus transcend generations. You must know that targeted therapy is now available, and non-targeted therapy is therapy as well. And reduction and removal of medications also forms a part of treatment. So that's all I have to say today. Thank you. I'm happy to take any questions from the audience if they have.
Thank you, Dr. Saurabh Malhotra, for the wonderful presentation. Can we stop the slide? Okay, any questions on the floor? Anyone would like to ask any questions on the
Hello.
subject?
Good morning. This is Dr. Elvin Chen from Hong Kong. Thank you very much, Dr. Malhotra.
Malhotra, right?
Yeah, thank you. Also, Sarab. Thank you very much for the very interesting lecture. You know, I am a pediatrician, so it looks all new to me and very interesting indeed. Yet, I think for my own sake and for my friends, I should know this more, of course. So I just wonder, well, in general, the male to female ratio is 50-1, right? But from your, say, for AL, from the graph that you've shown us, the male to female ratio, the columns were much more comparable for male and female, say 3-2 or 2-1. It's not 50-1 like that. So of course, this is a much rarer form of amyloidosis. I just wonder, for the different types of amyloidosis, is the male to female ratio the same, or of course different? How different are they? And also for ethnicity, is it different for Chinese, for Indians, for Africans and Caucasians, etc., and Hispanos? So just for interest sake, I just wonder, because I don't know, I haven't searched this topic in our own locality, whether its prevalence is similar to that in USA, etc. So could you enlighten me? Thank you.
Thank you, sir. Excellent questions. And so the AL amyloidosis is a much more rare disease, and there the prevalence is somewhat similar, and it's determined by the occurrence of multiple myeloma and plasma cell dyscrasias. So with respect to transthyretin amyloidosis, the two forms, the wild type or the senile systemic, the reason we used to call it senile systemic was it occurs in older patients, hence the term senile, which is not a good word to use anymore. We don't call people senile, so we call it wild type. The wild type amyloidosis has been noted to be more prevalent in men. We don't know why that is the case, and that is where the prevalence is 25 to 50-1, male to female. When it comes to the mutant form of amyloidosis or the hereditary amyloidosis, the prevalence is more equal, 1-1 or maybe 2-1 for men and women. And it's usually about 1-1, 2-1 across all different types of genotypes. So in the US, we have the V142I mutation, which is prevalent, which is also 1-1 or 2-1 prevalence between men and women. But the age of onset of that disease is a little late, I would say 65 to 70 years of age. When patients have the V30M mutation, they are much younger. People have amyloid in their 40s. The V30M mutation has been reported in Japanese populations as well. Now, when you come to Asia and Southeast Asia, I'm sure there has been, just like there has been in the United States, a lot of intermingling from Western Africa in the US. It is possible that some of those that genotype may have trickled down over generations. V30M mutation presents much earlier. The T60A, which is seen in Irish populations, would be somewhere in between the occurrence of the V30M and the V142I mutation. So the knowledge of mutations is important. And as you said, you're a pediatrician, and I'm often asked this question when we talk in terms of genetic counseling for our patients. I'm treating grandma today, but we found the mutation in her 50-year-old daughter, and she is concerned, oh, what about my children, and so on and so forth. So it's a generational disease, and we're not recommending that you test children. We only test people above 18 years of age here. But I think knowledge of the parents having or carrying the mutation is important, because it's a heterozygous autosomal dominant mutation. So if you have a parent who carries the mutation, it's a 50% likelihood that the mutation will be transmitted to the next generation. So the kids will grow up from your care, but they may still live with the mutation. So having a family knowledge as to what their family has been dealing with would better inform your patients who will grow on to become adults at some point, that they need to look out for symptoms that could be from amyloidosis. It's a debilitating disease. It starts with neuropathy. Patients lose their fine motor skills and gross motor skills. A lot of time it results in loss of occupation. Patients are not able to work because they don't have use of their hands, or not as efficiently as they would like to. So I think having a knowledge of this disease, especially when it is a hereditary variant, is very, very important from that standpoint.
Yeah, thank you very much. Can I have a follow-up question then?
Please.
Yeah, it's very enlightening to know this, but of course, psychologically, it becomes a burden for the young men and women to know that they will have the disease later on, debilitating one, and for their marital counseling as well. So I think that is important to know, and in fact, the doctor should be coupled with the psychologist advice. I just wonder, say, in children, we discovered that autistic spectrum disorder had increased in the incidence from, say, 3 decades ago to the current one, say, 1 in 60 or 58, even for the males, etc., etc. I think for amyloidosis, it's much more scientifically, discrete than that in autism. So the genetic spectrum is so clear-cut in this disease. But how do you explain that the prevalence have been increasing all along? Say, your graph had shown that the current prevalence have been double or even triple that of 3 decades ago. So what is the reason? Is that due to, like many of our naturalists had talked about autistic children, that is the environmental one, is due to the vaccination, or due to anything else? As scientists, pediatrician, we don't believe in that currently. But what about amyloidosis? What's the reason of this increasing prevalence? If it is just such a genetic, autosomal dominant heterozygous one, why is it increasing so much? Thank you.
So excellent question. So there are, I think that there are a couple of reasons, and I'm going to put my public health hat on this one. So one of the reasons is people are living longer. We are making people live longer. If they're living longer, the same patients who we otherwise would say are going to die from aortic stenosis or valvular heart disease because we cannot operate on them, we are making them live longer by providing them transcatheter valves. So they're going to live longer, they're going to have more chance of developing disease and giving us more chance of diagnosing the disease. So I think the change in longevity here is one of the features. The second is, of course, the knowledge of the disease prevalence and our ability to diagnose. Now, if you go back to 2000 and before, we weren't doing as many cardiac biopsies and things of that sort, which we were doing more often in the last decade or so. We got better at it because of heart transplantation, which required repetitive biopsies after patients received heart transplant to look for transplant rejection and vasculopathy. So I think it's a combination of both our testing ability. Now, MRI came about in the foray, and it's very, very diagnostic of amyloidosis. So I think a lot of those things happened in the last decade. Patients are living longer. We have better tests. We are doing invasive biopsies more often. That made us realize that patients are actually, what they actually have is a lot of amyloid, which we just did not know. So I don't think we don't know that there is an environmental factor here. We don't know why wild type amyloidosis happen. We know why hereditary variant happens. And those are single gene, single mutation disorders. And to coming to your initial comment on the psychological aspects, and that is very, very critical. When we counsel our patients, their relatives actually, who are asymptomatic, unaffected relatives, not all of them want to get tested for the very reasons that you pointed out. Many don't want to know. There are, at least in the US, ramifications related to insurance and life insurances and medical insurance and wills and so on and so forth, which I'm sure may happen elsewhere as well. But I think the understanding and the support that we can provide our patients is that the field is advancing by leaps and bounds. Till about 3 years ago, we got these new drugs, the silencers and the stabilizers. This year, we found that we can actually do gene editing in the body. So that's where the field may go, and we know that these are single mutation disorders. So if there is a mechanism of correcting the genetic abnormality within the body itself, people may not even develop the disease in the future. So I think there is a lot to learn about this condition in the future, and a lot we'll see it's expanding enormously. And I think when we talk to our patients about potential treatment options, our ability to diagnose them earlier and to really give them an opportunity to limit or actually not develop the debilitating diseases that they may otherwise experience, I think is reassuring to them. And I think we have to talk to them with that level of confidence.
Thank you, Dr. Saurabh Malhotra. Can I just have a question to you? Hello.
Yes, go ahead, Dr. Chaudhary.
Yeah, thank you so much. This is a very good lecture, and it's very useful also, because you were just telling that it's that yes, it is a rare disease considered, but you have shown the figure that it's not so rare. It's good. Okay, so do you have any statistics on other part of the world, so that we can look into it? And moreover, the second question is, there is you were telling peripheral neuropathy is there, and with cardiac amyloidosis, is it that coexisting the peripheral neuropathy also, or is some other type of amyloidosis there?
Yeah, so Dr. Chaudhary, excellent question. So, unfortunately, the data that we have is very very stark. Either it's the Western hemisphere and it's the Far East. We don't have any information for in between. So we don't know what the prevalence is in Southeast Asia, in Bangladesh, in India, in Africa. Now, Africa, we can extrapolate because we know that African Americans have the mutation, and Western Africans, we see a lot of patients from Ghana, from Nigeria, from Ivory Coast, in Cook County, that we know have the disease. But when it comes to sub-Saharan Africa, other countries, and definitely Southeast Asia, we do not know what the incidence and prevalence is, because we came out of, I don't know if we are still out of that, you probably know better, of infectious disease which is endemic. Then we developed an epidemic of chronic diseases, diabetes and heart disease. Now we have COVID. So I think patients and people in Southeast Asia have been dealing with so many other much more common medical conditions that I don't think much attention has been paid to cardiac amyloidosis. Now, I must have to confess, when I was a medical student in Delhi almost 2 decades ago, my attending on medicine would always put amyloid as the 10th differential. And I could not figure out at that time why he would do that. But he would always invoke amyloidosis in his differential diagnosis. And now I'm appreciating that fact as to why he would do that. The advantage that we have now is if we have that suspicion, we can confirm that suspicion. 2 decades ago, it was just bookish knowledge that we could not confirm. We have an aging population in South Asia, in India, and Bangladesh, and if patients have lived on till 80, 90 years of age, and they all of a sudden develop heart block, or they are now not able to tolerate the antihypertensives that you had prescribed them, then that is amyloid. And I think we really don't know what the exact number of incidence and prevalence is. We can only speculate that the wild type amyloid, if we take a loose percentage of 25%, multiply that by number of 80 years old in your country, and you'll get some sort of an idea as to how many could have amyloid deposits in their heart. Are they going to be symptomatic from it? We don't know that, because these were autopsy studies. After death, we found that these patients had amyloid. But that is a very sobering statistic, even though from a small population, it's going to be, I don't think it's 25%, maybe it's 10%. Even a 10% of population in Southeast Asia above 8 years of age has amyloid in the heart. That's a pretty substantial proportion of patients who can have heart failure, heart blocks, so on and so forth.
So actually, there is a relevant question actually, if you know. This is actually, in late onset diabetes, if it is developing like 70s, and then and having the peripheral neuropathy, do you think that he should go for the test for amyloidosis?
So that's a very, very great question. Excellent question. So I struggle with that concept here. Our patients have a very high prevalence of hypertension and diabetes, both of which can actually mimic symptoms from amyloid. What I tell my colleagues is, if your patient has bilateral neuropathy, which you think could be from carpal tunnel syndrome, or if the neuropathy is looking like carpal tunnel syndrome, diabetes does not give you bilateral carpal tunnel syndrome. It will give you some peripheral neuropathy. But if the patients are saying that they get pain in their wrists and they can't use their fingers, that's a problem. Now, carpal tunnel syndrome is not a neuropathy. Carpal tunnel syndrome occurs in amyloid due to deposition of the protein in the transverse carpal ligament. So it's not a neuropathy, although the features are that of neuropathy. Other things to remember are lumbar stenosis, so on and so forth. Now, in diabetics, the neuropathy is linked to not only the disease duration, but also the disease control. So if you have a patient who has well-controlled diabetes and they have polyneuropathy, gastroparesis, autonomic dysfunction, that would be very, very unlikely to be from diabetes alone. So I think, as I mentioned, we have all these good tests, and we're shooting rockets to the Mars, but at the ground level, we have to put our clinical hats, and we have to be astute clinicians to decide what really the patient has. Is this neuropathy from diabetes? Could there be something else going on? And if you are suspecting that, and we do this routinely, we send them for a formal neurology evaluation to get EMG studies done, nerve conduction studies, to see if they really have mononeuropathy and sensory neuropathy. But it's definitely a challenge. There's no doubt. And the first question I'm asked every time I see a patient like this, but this could be from diabetes, this could be from hypertension. So the only way we can identify amyloid is if we have amyloid at least as the 10th differential, if not the 5th.
Okay. Surab, can I?
Yeah, just Dr. Heidi, you have a question? I think you're trying to ask a question, and then we can.
Yes.
Yeah.
Thank you. Thank you so much, Dr. Malhotra. Very interesting talk and lecture. I'm an anesthesiologist myself, or a specialist in intensive care. And I agree with you that differential diagnosis, could it be amyloidosis, is very useful. I was taught the same way. And I'm very thankful for that. I had a question about the CRISPR study. There's it's very interesting with both, of course, with the CRISPR technique, but also with this study published in the New England Journal of Medicine. Do you know if there are more? And this study had 6 patients. You said, yeah. Do you know if there are more studies going on likewise? Multi-center studies or something?
I don't know. I would be very surprised if they're not. I think this was a proof of concept study. Not only did it show that you can do it in vivo, which is excellent. You don't have to do any surgery. You give an intravenous injection. The CRISPR goes to the liver, and that's where the TTR is made. There's no other organ except for choroid plexus. 90% or more, 99% is made in the liver. So it goes, it homes in on the liver, goes inside the cell, finds the mutation, and cleaves the DNA at the mutation itself, and allows the body's normal repair mechanisms to repair the DNA where it sliced the DNA. I don't think from that study, at least, we have seen any adverse or unanticipated events or effects from that modification in the DNA sequence. But I think that is a concern. We don't know that yet, but I'm pretty sure there are going to be more treatments like this or more studies like this coming along in the future. And the reason being, we know the genes, the mutation that cause these. We know exactly where these mutations are in the genetic code. There are about 220 mutations that we know of. So if we can target the mutation itself in the body, conceivably there will be no disease. But we'll have to wait and see what happens in the future.
Thank you.
Okay, Saurabh, can I?
Yeah, Dr. Sajad, right? Please ask your question.
Saurabh Agarwal.
Yeah, go ahead, Dr. Sajad, ask your question. Yeah. Dr. Sajad, go and ask your question. Yeah, okay. Can you hear? Yeah.
Thank you. Thank you very much, Dr. Malhotra. It was very informative presentation, but I missed the early part of your presentation. I am a ENT surgeon and belongs and Secretary General Pakistan Medical Association. I just want to know the basic thing that how this disease is presenting in the beginning, the symptom, number one. Number two, how can we prevent them? Any prevention? And is at what age is this disease is related to any age of the person? And the lifespan of, if anybody suffer from this, how much is the lifespan? Lastly, is it autoimmune disease? I'm sorry for all these questions. Thank you very much.
So Dr. Sajad, excellent questions. I do not know if this is an autoimmune disease. Now, I always joke about this because I showed a slide that showed that use of doxycycline as a potential agent to cause fibril disruption. And the only people who get excited when I say that are the infectious disease doctors, because they think that all chronic diseases have infectious etiology. But we don't know that. And I think if somebody finds that out, they should get a Nobel Prize. Autoimmune, we don't know. We don't know why the wild type, which is the most commonest form, happens. So that is not preventable, at least from our limited understanding of why the wild type disease happens. Is there an autoimmune mechanism? I don't know, but there is a wild type mutation that results, again, in transforming that protein. So the protein has to be disrupted. So a mutation has to happen that results in disruption of the normal structure of the transthyretin protein that makes it become unstable, which results in formation of fibrils. Now, so we don't know for the wild type. For the mutant variants, we know that there is a genetic mutation that causes that. There are a number of mutations that cause that. And to your question about is there an age relation with age, and there is a relation with age because certain mutations express the disease at a certain age. So the patients that we see at County in inner city Chicago, we would say their disease expression starts to occur about 60 years of age. So if I have a patient, 80-year-old grandmother who has this disease, and she has a 8-year-old child, I am testing them then, and then I'm testing them again when they are 60, because that is where they're going to start expressing the disease. The gene is going to start expressing. So that's where the penetrance of the genetic code happens. And depending upon the type of mutation you have, and I'm talking a lot about these genetic mutations, this is going to become the norm in the future. Knowledge of our genetic code in the future, and really doing precision medicine based on this information. Again, this is not without caveats, as was mentioned from our senior colleague from Singapore. But that will help us decide when we expect the disease to happen. So if you have the V30M variant, the Japanese or the Portuguese variant, those patients express at about 40 years of age. So they may start showing their symptoms at a much earlier, 3 decades or 2 to 3 decades earlier than patients in the US, and their symptoms are more likely to be neuropathic symptoms. Whereas patients in the US who express and whom the disease is seen about 2 decades after the European counterparts may actually have more heart failure symptoms. So the type of mutation also decides the types of symptoms that may predominantly be seen. Now, we often seen a mixed bag of symptoms. There's always some bit of neuropathy and a lot of cardiomyopathy. We have patients with the mutation who have no cardiomyopathy, who only have neuropathy also. So it's a spectrum, and it just depends upon where on the spectrum you find your patient. If you find them early enough, they may not have the cardiomyopathy. Unfortunately, when you develop cardiomyopathy, the lifespan is reportedly 3 to 5 years, depending upon the type of mutation. With the wild type, the lifespan tends to be longer. With the mutant variants, the lifespan tends to be much shorter. I have seen patients pass away within an year after we diagnose them with cardiac amyloidosis with the mutation. The AL amyloidosis, which is the much rarer one, the traditional thinking was it's about 6 months lifespan, but now the treatment and the chemotherapy and the bone marrow transplants have done so well that those patients actually can have a fairly prolonged lifespan.
Right. Thank you very much, Mohatra. Thank you.
Thank you for your question, sir.
Thank you. Do we have any other questions on the floor? I think it's a wonderful discussion going on. A lot of good questions coming in.
Thank you, Sharab. Thank you very much for the excellent presentation. I just like to know, apart from the cardiac, does it also involve the renal and the lung amyloidosis? Is there any presentation? Thank you.
So we definitely see renal involvement in these patients. We have not, we don't talk much about lung involvement, and I'm not sure why that is the case. Definitely renal involvement. A lot of these patients have chronic kidney disease and renal failure that we tend to attribute to hypertension, diabetes, so on and so forth. Actually, if you do their renal biopsies, several of them actually do have amyloid. So renal, yes, kidneys are definitely involved. Gut is definitely involved. A lot of these patients have gastroparesis, dysmotility disorders, marked constipation. so much so that there is a loss of appetite, there's weight loss, there's temporal wasting. I have not come across, I actually have not even heard from other colleagues of mine about predominantly lung problems. So I don't know of a lung phenotype or how the lungs could be affected in amyloid. I don't know of any literature on that, but conceivably it could. It's a systemic disorder, like I said. It's like diabetes. Now, diabetes really doesn't affect the lungs per se. Maybe there's something similar in both, because again, like diabetes systemic disorder, you can have cataract and glaucomas, heart disease, kidney disease, and it's the same kind of distribution for amyloid. You have it in the brain, glaucoma, macroglossia, cardiomyopathy, neuropathy, and gastroparesis, autonomic dysfunction, and then renal failure. But I do not know specifically about the lungs.
Oh, thank you. Thank you so much.
Any other questions coming on the floor? Okay, Saurabh, just one question which has come up in the Facebook chat is, in your particular field, I know it's related to COVID again, and do you have any guidelines for the vaccination for extreme sick patients in your field? Is that like, are you advising the vaccination? Is there a protocol, something like that?
For patients with amyloidosis?
Yeah, and having a COVID, like
Yes,
post-COVID or
they
something,
they should get vaccinated. Yes, absolutely no reason to not get vaccinated. Actually, I would say if they have heart failure and they are at the highest risk of having adverse outcomes from COVID itself, if it was to affect their heart in terms of myocarditis and so on and so forth. So yes, absolutely, definitely they should get vaccinated. There is absolutely no reason why those patients should not get vaccinated. And all of my patients who at least I see who have amyloid are all vaccinated. 2 of them actually have survived COVID infection. So definitely they need to get vaccinated. Yes.
Dr. Malhotra, just in this regard, I have a question actually. I have seen one of my friend actually got the heart attack just immediately after the vaccination. Do you think that is there any correlation between these two?
There is some data. So again, Dr. Chaudhary, it depends upon what the and we also always say how was the heart attack classified? Was this just a troponin elevation that was called as a heart attack? It could be myocarditis. Oh, okay. So there are reports on vaccine-related myocarditis. The incidence is very, 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 very low. Considering how many vaccinations have been administered, we actually are submitting a paper on of a systematic review, and we only found about, at least when we did the review, about 75 cases of COVID-related myocarditis. I do not know if your colleague, what he experienced was from vaccine itself, or was it perhaps an embolic or a systemic embolic phenomena that can happen in patients who are infected with COVID. But we have not seen, unlike when COVID first came, we were seeing a lot of these thrombo-occlusive events, which presented as myocardial infarctions. We have not seen that with the vaccination to that extent. I have not seen a vaccine-related myocardial infarction. Now, it is very possible, again, I'm putting my public health and epidemiology hat here. Your friend may have coronary artery disease to begin with, and his symptoms may have been from myocarditis and not from plaque disruption, and his tests and elevated troponins and his symptoms may have resulted in an angiogram that may have shown a 70% stenosis, and our oculostenotic reflex would result in putting a stent there. So again, I think the cause and effect is different. There can be confounders existing. There could be symptoms related to the vaccine, completely unrelated to why your friend may have had an MI.
Can it be just related to the previous, actually in the initial stage, when the people were going for vaccination, there were a lot of actually scary situations, actually a lot of this saying that yes, this will happen, that will happen. So just maybe the reason that triggered actually is anxiety and others maybe.
It's possible. Anxiety and emotional stress can cause MIs. It's possible. I cannot. I think the easier answer is that your colleague had something other than MI, and when an angiogram was performed, he had a stenosis, which was thought to be the problem. That is my suspicion. Having seen several scenarios like this play out in clinical practice, where you have to tease out, are the symptoms from what we are seeing, or are there more than one thing going on, just like amyloid? Is there more than one thing happening at the same time?
Okay, that's a lengthy session. Do we have any more questions coming up? We have 15 minutes to go. If we have no questions, then I would like to introduce the speakers. We also have Dr. Veena Agarwal, wife of Dr. KK, also a gynecologist, to just say hello to you guys. It's a Perfect Health Mela. Dr. Veena, are you there?
Yes, I'm here. Yeah.
She has also done a presentation on this platform, and I think she was a patient with all three variants, I believe.
Yes.
And that was a presentation which came up from her.
Yeah. So good morning to all of you. A very, very warm welcome to Dr. Heidi, who's our special guest today. I've had the opportunity.
No, she's a special guest for all the sessions now.
Oh,
we have
okay.
taken a permission.
Yes. We would like her to be. We would like her to be a part and not a guest.
Yeah.
I've had the opportunity of visiting your beautiful country and look forward to doing that again. And Dr. Malhotra, very, very lucid presentation. Congratulations. The fact that so many questions were asked was a good indication of how well your presentation was received. And I'm more emotionally stable now, so I'm able to be present here. I hope to be present in future sessions too. A big thank you to all of you for continuing this legacy and carrying this forward. Thank you so much.
So this was Dr. Veena. Thank you, Dr. Veena, for coming up. So I would just like to quickly introduce all my speakers. So this is a SIMAO session. We have about 19 countries from Australia, Bangladesh, Cambodia, Hong Kong, India, Indonesia, Japan, Macau, Malaysia, Myanmar, Nepal, New Zealand, Pakistan, Philippines, Singapore, Sri Lanka, Taiwan, and Thailand. We also have a lot of guests coming in from US, Canada, all other countries around the world. So this is more of an international session. Sorry? Brazil, right.
Yeah.
So Brazil, I will come. I'll come because it's 2 o'clock and she was asking me a time to leave, and I said, no, you're not leaving. I'll take a privilege to steal your one night over there. So,
I think also it's a late night for Dr.
It's 2 a.m. Yeah, it's 2 a.m.
Dr. Hedy is really, it's now, what's time now there?
In Sweden. What time is it in Sweden?
So,
So now it's in Sweden. Now it's 7 o'clock. 7 o'clock. Quarter past 7.
Oh, that's not bad.
Oh, not so bad. I thought that it's 4 5.
So the worst victim is Deborah from Brazil. She's in 2 a.m.
Yeah.
Okay, so I will quickly announce the names. So we have Dr. Heidi Stinsmer. She's the 72nd president for World Medical Association. I welcome her and for all future meetings without asking her. We had Dr. Chong. He has to leave for a meeting. He was from Singapore Medical Association and also the chair for SIMAO. We have Dr. Ravi Naidu from Malaysia Medical Association, Dr. Nazmi from Pakistan Medical Association, Dr. Alvin from Hong Kong Medical Association, Dr. Pillai from India Medical Association, Dr. Salma from Pakistan Medical Association, Dr. Angelica from South Africa Medical Association, joined by Dr. Akhtar Hussain Dr. Jamal Chaudhary from Bangladesh Medical Association, Dr. Mukti from Nepal Medical Association, Dr. Subramaniam, Dr. Ravi from Malaysia Medical Association, Dr. Sajad again from Pakistan Medical Association, Dr. Prakash from Nepal Medical Association, Dr. Bennett from Philippines Medical Association, Dr. Deborah from Brazil, Dr. Marie from Japan, Dr. Russell from UNESCO, Australia, Dr. Qazi from Pakistan, and also President-elect Simao, Dr. Kun and Dr. Sen from Korea Medical Association. We also used to have Dr. Shashank Joshi from India COVID Task Force, Dr. Bukhari from Pakistan, Dr. Brahm Vasudev, Dr. Monica Vasudev from US, Dr. Sanchita from IGCP Group, Dr. Meenakshi from, again, Heart Care Foundation of India. And before we can open, we have just 9 minutes, so we can just have a chit and chat because we don't think we can do a country update.
May I have a question to our president, new president of WMA?
Yes, and I just want to invite her for a talk. I just want to have a good news announced over here. India has encountered 1 billion vaccines yesterday. So it is a big success, which I did not want to leave the session without announcing that. It's a 1 billion vaccine, which is a record.
What is in terms of percentage of the targeted?
It's I think it's about 35%, if I'm not wrong. I have to just check. I'll just come back on the number. Over to Dr. Heidi Sisman for the remarks. I don't think we have enough session to move forward. We just have 9 minutes.
I was asking one very important question.
Yes.
Yeah. So actually, this also was raised actually in the WMA conference ended General Assembly just ended recently. That actually the recognition of the various vaccines by the countries of the world. This is a very prime thing and very important matter because this restricts the traveling. And when WHO is recognizing some vaccines, even some countries, they are not recognizing those. WMA should raise its voice more steadily and continuously should raise its voice, I think, regarding this matter. What do you think about it?
Thank you very much, Jamal. Thank you very much for asking this.
Yes, actually, there is a discrimination even within the estrogenic also.
I think, Dr. Jamal, your question was not very clear to Dr.
Not clear? Oh, sorry.
Yeah. Can you speak that again?
So again, I'm doing it actually. The countries of the world, they are not recognizing all the vaccines recognized by WHO. And in the last conference, WMA conference, that actually WMA has recognized it and just they have raised their voices. Okay, fine. And I would like to thank Dr. Sajjad, that he has written to the WMA and it has been nicely addressed here. But what do you think? Do you think that it should be raised continuously so that it can get affected? Because even the AstraZeneca, it doesn't. It's India produced from India. That is the Covishield. In the name of Covishield, this is biosimilar to AstraZeneca, and unfortunately, UK is not recognizing that Covishield. Yeah. That is a very pity matter. So, what to do about this matter?
Yes. Thank you for asking this question. We had a talk with the WHO.
Can I just add on this what Dr. Jamal has asked? Can I add supplementary something just for your information? Actually, as a Secretary General Pakistan Medical Association, I have written a letter to WHO also, the Director General WHO, and requested him in the month of May 21st, that the vaccine which is recognized by the WHO, that can be accepted to all over the world, because some countries are not accepting some vaccines. So I have written and requested the WHO to just accept all vaccine which is being recognized and accepted by the WHO. So then after that, I have written to the WHO, WMA, World Medical Association.
Dr. Sajjad, your connection is...
this voice and ask every vaccine which is being accepted by. Now, can you hear me? Hello, can you hear me?
Yes, yes.
Yeah, now we can hear you.
Okay, just I'm going to finish that. I just want to, Dr. Ravi, to just raise this issue so that every vaccine which is being recognized by the WHO should be accepted to every part of the world. Thank you.
Yes. Yeah, and I believe we totally agree on this this topic, all of us, and it really contradictory when we have such a need to vaccinate the population, and at the same time, national governments are not recognizing the vaccines given. So that is very counterproductive, and I think we can all agree on this. And I don't know if we had the awareness when we started out vaccinating and promoting vaccinations to all countries that we would reach into such a problem with the discrimination of the acknowledgement of the different vaccines. And this is one effect of the ground problem of a lack of a global agreement on this, and this we see in different sections, but now with very severe results here. And as we stressed when we had the press conference with the WHO on Thursday, we stressed the importance of global agreements on this, so that we have global playing rules. Because it's costing us extremely in resources when we do not recognize all the vaccines. And we also need to stress this through our national governments and national organizations, because we do have impact in each country as medical associations as well, to push for our governments, to push the other governments to recognize the vaccines. We do have a severe situation, unfortunately, with the lack of vaccines in many countries, and it's going too slow. So if we are not hurrying and distributing the vaccines available to the countries that are lagging behind, we will have huge problems very soon. It's quite critical. And then the discrimination of the different vaccines seems like it's almost like we can't believe it's true, because it's just creating a problem that we do not need at the moment, and we do not have time for this actually. So I can just thank you, Dr. Saeed, that you wrote the letter then, but we are not there yet. So we need to keep the pressure up for this and raise the awareness. And I can only add, it seems like very, very strange, very contradictory when we fight to get vaccines, that this is just an obstacle that is totally unnecessary in this ways. So yes, we are keeping the pressure up, and I think we need to target this along with the vaccine equity issue, because if we don't raise it, the risk is that it's being not forgotten, but it takes too much time before we have effectuated the recognition of the different vaccines. So we will keep the pressure up.
Thank you so much. Thank you.
Okay, Dr. Hedy, can I have your email or contact number so that I can send you the copy of that letter which we have written to the WHO and World Medical Association? If I have your email.
Or Dr. Sajjad, I will send it to you over the chat. I can send you her email.
Okay.
It says.
Okay.
Yeah, it's a public platform.
Thank you.
Yeah.
Thank you. Thank
You can do that.
Thank
Yeah.
you.
So,
Okay, thank you very much. We can use you as a pressure group.
Yes.
Okay, thank you very much.
Yeah.
I think so, Dr.
Definitely.
Heidi, I just want to say that this platform is actually also not only a platform where we can all meet, like, during this pandemic, we have seen the importance of bringing all the countries and we were actually getting data from all countries, and we were trying to analyze what's happening in each country. And also, it's a think tank and a roundtable kind of a conference for international meetings. We did not stop these meetings for any of the, even if there was like 2 participants, we did continue these meetings, and that is the reason we have been so successful now. And Dr. Jamal, I just wanted to answer your question. We have about 75% of the population of India which has got 1 dose at least, but only 30% has gotten fully vaccinated.
Oh.
May I ask you, Sarabha, do you always have the morning session before this session in the morning?
Absolutely. So I told you, okay, so I will again explain how does it work, and I'll just take a minute. We have another conference coming in after the next 5 minutes. That's a roundtable for a domestic, all the stakeholders of the government. And we work on the policies, and we put a pressure on the government of the Indian. So today also we have, if you continue on this session, you will see the sessions, and people are already joining in. So, there was a time when we used to do a session from morning 8 o'clock till 8 o'clock in the evening. And we have today we have a Perfect Health Mela where we have all kinds of, sessions going on. But otherwise, when this, Mela is not happening, which is an event, a health awareness event, we do have 3 sessions every day. Morning 8 o'clock, we have a session. We have a 9:30 a session. Then we have a 2 o'clock session. And then we have a 7 o'clock session. And all these sessions are only meant for public awareness. So we have experts, we have international guests, we have domestic guests, we have policymakers, we have even teachers, students. Recently, we did a session on the children where we were trying to understand why the schools are not getting opened. So all those things are there, and it's free for everyone.
Great. Impressive. Oh,
so I just wanted to share, since everybody knows personally Dr. KK, we just had a session last week, yesterday, where the kids, kids from 2 years, 4 years, 3 years, 10 years, they came up. Oh my God! Hi, welcome, new guest.
New guest.
New guest. You have any question, guest?
You want to participate?
But I think that there is a question actually raised. I have seen it there, but we just mentioned about those vaccines recognized by the WHO. That is WHO. It's very complicated, and it's a lengthy one also, recognizing the vaccines. So we have to rely on that. So that cannot be questioned actually. Tranjili.
Thanks. I'm just warning or cautioning that although we say that we need to accept all the vaccines that's been approved by the WHO, we also need to understand that for some countries like us, the data is quite clear on the Sputnik and HIV, that, I don't think that South Africa would accept Sputnik vaccinated people.
No, that is not recognized still by the WHO.
Okay, now I'm fine with that. I'm fine with that. I'm just saying that we need to be careful. We just need to look at all the data and also understand that some countries will have their own preferences. We cannot really take that away, as each and every country needs to also double check on what is important for their own people and the health in their countries. That's all I'm saying. I'm not disputing everything. I'm just cautioning. Thanks.
Even today, actually, I just came to know from the BBC, I think, that Russian people actually, they are not recognizing their vaccine. So they are not going for that vaccine also. It's very hard. So there are a lot of actual infections and deaths also are there in Russia.
Okay, so I would take a privilege to close this session. We have another session waiting up. Anybody who wants to join the next session is welcome. Otherwise,
we would like to actually welcome Dr. Veena Agarwal. We are really happy to see her here. Actually, we want to see her here because we love Dr. KK Agarwal from our heart. Thank you so much for your presence. And again, thanks Dr. Heidi to make time to join us here. Thank you so much. Dr. Robbie, I can see you didn't say anything to us today. Doctor.
So we will probably have next session where we will take a
Today I'm silent. Today
Okay.
I'm a silent listener, Dr. Chowdhury.
Today he has a punishment because he didn't join early. He was the first person every time joins. Today he's the last person.
So sorry, very, very sorry.
No problem.
Thank you.
Okay, so thank you everyone for joining the 81st
Thank you.
session.
Thank you very much.
Very nice.
We will.
Thank you.
I will send
Thank
the
you,
link
sir.
of this platform to everyone. Thank you so much.
Yeah, thank you.
Thank you.